Hello everyone and welcome back. So let's discuss the topic Thalassemia Major from hematology. So we are having a scenario that there is a 3 years old child has severe anemia and hepatosplenomegaly and there is history of repeated blood transfusions in him. His elder sister also has same problem and two of his cousins had died of same illness. So what are the diagnosis, investigation, findings and mode of inheritance and questions you will ask, and what is the short term and long term management of Thalassemia Major? Another scenario is that there is a couple who come to you with complaints that both are having thalassemia trait. Now lady is pregnant again. Couple is worried of having thalassemia major. A baby is there is elder daughter in thalassemia major. What are the investigations, the inheritance and the risks of having normal baby and the trait in pregnancy? Okay, the next scenario is that a parent brought their 1 year old child with severe pallor. On examination, he has massive hepatosplenomegaly. Parents are cousins and there is history of blood transfusions in elder children. So what is the diagnosis, the inheritance pattern of the disease, the investigations, the complications, and the supportive and the specific treatment options of thalassemia major? Okay, alpha thalassemia. It is autosomal recessive disorder and there is decreased alpha globin chains and excessive beta chains in alpha thalassemia. Alpha chains are 4 in number and expressed both prenatally and postnatally. Alpha thalassemia is due to gene deletion. Okay, what happens in the alpha thalassemia? That normally we are having 4 alpha chains in number and these are expressed both prenatally and postnatally. So in alpha thalassemia, there is decreased alpha globin chain and excessive beta chain. And alpha thalassemia is due to gene deletion. This is the defect that lead to alpha thalassemia. Now we are having the types. These are silent carrier, alpha thalassemia trait, HBH disease, and hydrops fetalis. In silent carrier, we have the deletion of only one alpha chain. In alpha thalassemia trait, we have the deletion of two chains, that is beta thalassemia minor and mid anemia. In HBH disease, we are having it is characterized by precipitation of beta chains, and it leads to severe anemia. And in hydrops fetalis, there are the deletion of all four chains. Okay, in HPH disease, there is a deletion of three chains, and in the hydrops fetalis, there is the deletion of all chains. So these are the types of thalassemia. These are silent carrier alpha thalassemia trait, HBH disease, and hydrops fetalis. Thalassemia, so it is autosomal recessive disorder, and there is decreased synthesis of beta globin chains with relative excess of alpha chains. 4 beta chains and expressed pronatally, postnatally only. Therefore, anemia manifests 6 to 9 months after birth. So, beta thalassemia is autosomal recessive disorder, and there is decreased synthesis of beta globin chains with relative excess of alpha chains, and 4 beta chains expressed postnatally only. Therefore, anemia manifests 6 to 9 months after birth. Now, we are having beta thalassemia minor and beta thalassemia major. So in minor we are having B naught or B, and the diagnosis confirmed by decreased HbA2, while in thalassemia major we are having Cooley's anemia, that is homozygous, that is both two beta chains or absence of both beta chain is there in beta thalassemia major. In thalassemia minor only one chain is absent, but in the major beta thalassemia we are having both the chains absent. Now the clinical features are severe anemia requiring blood transfusions and secondary hemochromatosis due to many blood transfusions and bone marrow expansion and Checkman fishes. These are the clinical features of the beta thalassemia major. These are secondary hemochromatosis due to many blood transfusions and bone marrow expansions and chipmunk fishes. Now the investigation options for thalassemia major is HBO electrophoresis. There will be decreased fetal hemoglobin and alpha and gamma chain, and CBC there will be low MCV, decreased HB and target cells. The treatment options for thalassemia is that first of all investigations are done which are complete blood count. In thalassemia major, HB is usually false, which is 5 to 6 gram per DL or less, and HB usually is normal in thalassemia minor. So this is the differentiating point, that HB is usually decreased in the major and HB is normal in the thalassemia minor. Then the retics count is fine, that is relatively increased 5 to 10%, And RBC morphology is done, that is microcytic hypochromic anemia is present, anisocytosis, poikilocytosis, and target cells, and matured RBCs and precipitated alpha chains. These are checked. Then HB electrophoresis is done, which is diagnostic test. For thalassemia minor, there will be decreased HbA1 and elevated HbA2 and increased fetal hemoglobin. In thalassemia intermediate, there is decreased HbA1, HbA2 is increased. Fetal HB is 60 to 80% of the total HB. And in thalassemia major, HB absent, HbA1, elevated HbA2, and HbF. The serum iron is checked, which is elevated, and imaging studies are done, which is hair on end pattern in skull and thinning of long bones uh, is present. Okay. Now the management options for thalassemia is that first of all general management is provided, that is maintain the normal HB. Then transfusions therapy are done, that is packed RBCs and HB 10 gram per deal is given. Chelation therapy is provided, that is iron chelation therapy with defoxamine to prevent iron overload. Ascorbic acid is given to increase the urinary excretion of the iron. Splenectomy is done for hypersplenism. And bone marrow transplantation is done, that is stem cell transplant if HLA-MH is present, and gene therapy is done. Trait and father, and this is thalassemia trait in mother. So if in 25% no altered gene and normal, in 25% there is true altered gene and beta thalassemia trait, and in 50% there will be well altered gene and there will be beta thalassemia major. So we have discussed the topic the thalassemia major. We have discussed the scenario clinical case, that is that there is a patient with severe anemia and hepatosplenomegaly and there is history of repeated blood transfusions in him. Elder sister also has some problems and two of his cousins had died. There is genetic family history. In another scenario, there are complaints of having thalassemia trait and now lady is pregnant again and couple is worried having thalassemia major baby as their elder daughter is thalassemia major. Another scenario is that there is severe pallor child and he has hepatosplenomegaly and he is having the history of blood transfusion. So we have discussed the thalassemia, that there is alpha thalassemia contain 4 genes and there is absence of 1, 2 or 3 genes. So the 1 is silent carrier, the 2 genes is alpha thalassemia trait and SBS disease. 3 genes are lacking. In hydroxyproteolysis all the genes are absent. Then we have beta thalassemia, in which there are 2 beta chains. If 1 beta chain is absent, then there is the beta thalassemia minor, and if 2 are absent, then it is beta thalassemia major. The clinical features are severe anemia, secondary hemochromatosis, and bone marrow expansion and chipmunk facies. The investigations that are done are HB electrophoresis and CBC, complete blood count, retics count, RBC morphology, HB electrophoresis, and serum iron and imaging studies. The management option is provided as such. First of all, general management, then the transfusion therapy, then the chelation therapy for iron, ascorbic acid to increase urinary excretion of iron, and splenectomy for hypersplenism, bone marrow transplantation, and gene therapy. Now, a different questions is asked in the scenario that what is the inheritance pattern? So each child has 25% of inheriting 2 normal genes and 50% chance of inheriting 1 altered and 1 normal gene and 25% chance of inheriting 2 altered genes. That is beta thalassemia major. So this was all about the thalassemia. Now we will discuss the hemophilia in the next section.